So thank you all for being here. And in the next 12 minutes, we're going to talk how to evaluate mitral valve with 4D echocardiography. We know that this valve is a very complex valve. We have the subvalvular apparatus with chordae, papillary muscles, and two asymmetric leaflets, one large anterior, one smaller posterior. We have commissures, we have indentations, and scallops. If we want to appreciate this valve with 2D echo, then we have to take multiple projections, either from transthoracic echo or from transesophageal echo. And even with this, we cannot really name the correct scallops sometimes. Fortunately, we can demonstrate the valve very nicely with the 3D echo, the subvalvular apparatus, and the 3D and fast view of the valve. 3D echo helps us understand with the MVQ model or the 3D and fast view, the indentations, the prolapsing parts, with the tethering of the leaflets. We can measure correctly the area and the opening of a stenotic valve, and it's of great value. And you can see that from the surgeon's view has a strong correlation with what we see in 3D imaging, and we can also use 3D in Carpentier classification. We should never forget that the basic form of 3D echo is the biplane views of 2D images perpendicular to each other with the 3D probe. And first of all, in transesophageal echo, we need to start with a commissural view where you can see one moment. If we go with a commissural view, at the left side, we have the medial part, and at the right side, we have the left atrial appendage and the lateral part of the valve. So if we move our cursor towards the appendage, then we know that we appreciate the lateral part of the valve and the A1, P1 scallop. If we go towards the central part, we can appreciate at the elevation level, the A2 and P2 scallops. And if we go to the medial part, we can appreciate the A3 and P3. But of course, 3D echocardiography is this surgeon's view, is this left atrial perspective view of the valve. And if we place the aorta at 12 o'clock, then we know that we have the anterior part on top, the posterior part at the bottom, and we have on the left side of our screen the appendage and the lateral part of the valve, and on the right side, the medial part towards the tricuspid valve and the A3, P3 scallops. Even though we can take these nice transthoracic 4D images and appreciate a prolapse of mitral valve, when we refer a patient to a surgeon or interventionist, we should always perform transesophageal echo because we can see in more detail these valves. And of course, MVQ analysis is a method to take some measurements for the annulus and the leaflets, and these measurements might be very important for the surgeons and the interventionists. If, for example, a patient has to undergo a transcatheter mitral valve implantation and cannot take contrast agent, we can rely on this method because it has a strong correlation in measuring the annulus area and circumference, and we know this from several publications. At the moment, we can use 3D echocardiography in mitral regurgitation, mitral stenosis. We can evaluate prosthetic valves, and we can use it for transcatheter devices. In mitral regurgitation, we know that we have many reasons why MR can be developed. It can come from the leaflets, the annulus, the chordae, the papillary muscles, and the left ventricular wall. We need to differentiate the degenerative from the functional mitral regurgitation. When we talk about degenerative, we have to remember that mainly it's a prolapse valve. And in order to have a common language, like Dr. Fiore said before, we use the Carpentier classification in order to name the type of MR. In primary MR, 3D echo can help us understand the different phenotypes of the degeneration, the fibroblastic deficiency, the Barlow disease, the Former-Fruste, the ruptured chordae, and you can see the value of 3D echocardiography and creating the model of these valves. And by showing these examples, only by taking this 3D and fast view of the valve, we can understand that at the left side of the screen, we have a patient with a A2 prolapse with a ruptured chordae. On the right side, we have an A2 prolapse without any rupture of the chordae. These are different cases of posterior leaflet prolapse, a P2 towards the lateral part on the left screen. In the middle, we have a large P2 prolapse, and on the right side, we have a P3 prolapse with multiple chordae ruptured. This is a Barlow disease, mainly P2 prolapse, but you can see that all scallops are prolapsing. We have a very large mitral annulus, and the whole valve goes beyond the level of the mitral annulus. And it's important to know that because the surgeons need to have this information for if they are about to go to a repair. And as Dr. Özden said before, mitral annular disjunction is very important to know in arrhythmic syndromes and young people with malignant arrhythmias. We can appreciate this anomaly also with 2D and 3D echo. And as you can see, the hinge point of the posterior leaflet moves away from the posterior wall of the left ventricle. Sometimes 3D echo can help us in diagnostic dilemmas. Here, for example, you can see in transesophageal echo that in long axis view, we have something that is prolapsing from the anterior leaflet, while in the commissural view, we have the P3 part prolapsing. In transthoracic echo, again, something from the medial part going coming from the anterior part. So we don't understand if this is an anterior or a posterior leaflet, but however, it was a medial commissure prolapse, which was very nicely seen in 3D and fast view of the valve. In endocarditis, if we have a perforation, like in this case, you can see in the anterior leaflet we have a defect. And with color Doppler, we can appreciate two jets, one coming through the perforation and one coming from the coaptation line. But however, with 3D echo, we can see very clearly that we have a perforation in the A2 scallop of the anterior leaflet, and the color is coming only from this perforation and not from the coaptation line. So we were very accurate and very correct in our diagnosis about this patient with 3D echocardiography. In secondary mitral regurgitation, we have to remember that this is not a problem of the valve. It comes either from the left ventricle with segmental or global remodeling, displacement of the papillary muscles, and tethering of the leaflets towards the apex. It can come also from dilatation of the left atrium, enlargement of the mitral annulus, and a large central jet, which is called atrial functional mitral regurgitation. This is a typical case of functional MR. You can see a kinetic inferolateral wall, a dilated left ventricle, and the central jet in this biplane color view of the valve. And you can see that the A2 and P2 scallops do not coapt at all in this 3D and fast view of the valve. Vena contracta area is very useful in functional MR cases because we know that the pizza is not spherical. It is usually hemielliptic, or we might even have multiple vena contractas. Like in this case, you can see that we have two jets of MR and two vena contractas. And if we try to measure the ERO with 2D, we might underestimate the severity of MR in this case. And from this paper, we know that in DMR, we have a strong correlation between the 2D ERO and the vena contracta area, while in FMR, if we use vena contracta area, then we upgrade the severity of MR by 1 grade. In mitral stenosis, 3D echo is also very useful. We know that we should manage patients that have an MV area of below 1.5 centimeters square and patients that are symptomatic. And what we need to do is go with the 3D echo, the flexi-slice or the multi-slice method, and go directly at the tips of the leaflets. It's something that we cannot clearly see in short axis 2D views because we don't know if we are at the tips. We can take transthoracic or transesophageal images, and what we need to do is to trace the minimum area of the opening of the mitral valve. And that way we know that we are more accurate in grading the mitral stenosis, and we have strong correlation with CMR and color vena contracta area. In prosthetic valves, with 3D and fast view, we can appreciate this bioprosthesis with degeneration and two leaflets not opening at all. If we have a ring, we need to measure the area, the circumference, and several dimensions if we want to implant a valve in ring, because we know that there are several types of rings that are suitable for this method. And if we have, for example, a patient with previous repair and the presence of a mitral ring, then we can take this nice flexi-slice image of the ring and we can measure accurately the area and all the measurements that we need for a valve in ring implantation. In metallic prosthesis, we can see with 2D or 3D the functioning of the two discs. We should know the acceptable mean gradient according to the size of the valve we are going to use. But however, if we have a patient with a hemodynamic instability or increased gradients that we didn't see before, we can proceed to a 3D echo with a nice frame rate with a new probes and appreciate that one disc is dysfunctioning and it's not opening at all. In paravalvular leaks, also we can use 3D echo. You can see this case. We have several jets. We have transvalvular and we have paravalvular leak. So with 3D echo, we were able to appreciate that we have a dysfunctioning bioprosthesis with severe paravalvular leak at 11 o'clock. And we can also measure the vena contracta of the PVL if it is a case that it is suitable for a plug device. Of course, this is not about this case. There are some cases with a ring detachment. You can see here the severity of the hole we have. We can appreciate this anomaly with this pathology with the 3D echo, and these cases should go and have a reoperation again. And of course, in transcatheter devices, I will not say a lot because the next speakers will cover the topic very well. We know that we have several devices for every Carpentier type of classification. The most common one are mitral clip and PASCAL, edge-to-edge repair. And we need to know that if we don't have a 3D probe, then it's not feasible to complete this kind of procedures. So as you can see, 3D echo is evolving fast. It is indispensable for diagnosis and management of our patient, and it is necessary for guiding transcatheter treatments. In my opinion, in the near future, 3D echo will replace totally 2D in the assessment of mitral valve. Thank you for your attention.
Thank you very much, Kostas. And now I would like to